Is that sharing everything correctly? Cool. All right. So, good evening, everybody. Thank you for dialing in. My name is Matt Wordsworth. I'm a plastic surgeon by training, and I'm in the army, and I've just finished my training. I've got no disclosures. The opinions are my own. They're not part of the UK MOD kind of official policy or my NHS trust. I've got no financial disclosures. You don't go into amputee care as a plastic surgeon if you're financially motivated. And the photos are either open source or I have permission from the patients or colleagues. And there are some distressing photos, but they're not too bad. My kind of pre-hospital experience in amputee care is from Herrick 16 to Afghanistan with the army. And then I've just been in surgical training or research for quite a long time since then. And I'm just at the end of it, having finished my training last month. And I start at Imperial College, so in London, mostly at St Mary's Hospital in Paddington from next month. And a lot of my exposure to amputee care is from the Queen Elizabeth Hospital in Birmingham with the military and civilian surgeons up there, the Royal Free Hospital, Imperial College, and then mostly at Ohio State University, which is where I did my fellowship, really quite focused on amputee care. This presentation is probably slightly surgical for some people, but hopefully you can pull out some kind of universal concepts from it and find it interesting. And feel free to ask any questions as you go through, and then I'll try and get to them at the end. I'll start briefly just on the history of amputation, just so you get an overview of where the field came from and why it is still in some of the areas it is now. And then we'll kind of think about the concepts, some military considerations, and then really focus on function and pain and what surgeons can do to improve that for amputees, and kind of touch on some of the newer developments in the surgical space. So the actual first publication on amputation that I could find in the literature is from 1971. It's the Surgeon General of the Prussian Army who talks about how cruel and defective it was formerly and how mild and much improved it is at present. And so in the 1700s, they thought they'd much improved on amputations. And I think the start of medical publishing did mean that there was a sharing of ideas. Survivability improved, and people better understood what they were trying to achieve with amputations. But clearly, this was still being done without anaesthetic in pretty rudimentary surgical facilities. And so in 1805, it was the Battle of Trafalgar. So William Beatty in the picture there was the ship surgeon on HMS Victory with Nelson. And that's the surgical operating table he had and the equipment he had. And during the chaos of battle, he performed 11 amputations during the battle, of which 5 of those patients survived, which I think is generally considered to be a fairly good effort. He didn't actually treat Nelson at the time. They thought it was a fatal injury, which it clearly proved to be. But he did pickle Nelson in brandy and remove the musket ball later for the autopsy. So you can see amputation isn't particularly complicated surgically if you can achieve it with woodworking tools on a moving ship. And so in the 1800s, it was really about speed because there was no anesthetic, and the longer the wound was open, the higher risk of infection. So Dr. Robert Liston is famous for performing amputations in 150 seconds from first cut to wound closure. Unfortunately, even though he was well regarded at the time, he is now well known for an amputation that had a 300% mortality rate. He was chopping a leg off a poor chap, and that guy died of sepsis post-operatively. But during the course of his 150-second operation, he also cut his assistant's fingers off, and his assistant died of sepsis. And then he sprayed an observer with blood, and the observer was so shocked they died of shock at the time. So you want to avoid any operation where you kill 3 people from one surgery. But that said, 150 seconds is much quicker than I do my amputations. And so, people were aware that amputation was a mean yet potentially great surgery. And William Ferguson was actually quite an early proponent of limb salvage. He described amputation as the meanest yet greatest operation in surgery. Meanest only when resorted to if better may be done. Great as the only step to give comfort and prolong life. And so really amputation was all about, providing comfort and prolonging life. It was an ablative surgery to stop someone dying. And it was really the only treatment for open fracture or, a dirty gunshot wound in the limb at that time. But I think some people still see amputation as an ablative surgery. And actually, it can be a great operation. It can be a really functional operation. And so the historical concept for amputation is about survival. It's about ablation of a non-salvageable limb, and it's about speed. And some of those kind of hang-ups are still with us, but actually amputation is so much more than that now. And whilst rudimentary prosthetics existed from Egyptian times, this is an Egyptian toe that they found on a mummy, a wooden big toe. The speed and advancement of prosthetic care is such that amputation can be a really functional surgery from this point. And clearly there's a huge difference between amputating a diabetic foot for non-healing ulcers with chronic osteomyelitis and the kind of amputation that you saw with IED blast on dismounted infantry in Afghanistan. And this is the kind of the classic appearance. So this talk is going to be mostly focused on the kind of traumatic military amputee rather than the diabetic foot amputation. But it's worth bearing in mind that amputation care in the UK is about 70% diabetic. And clearly vascular surgeons are doing the majority of those amputations. Some of the concepts are relevant to both cohorts, and some maybe are not, but we're going to focus really on the traumatic side and the traumatic reconstruction. So, if you're dealt with a military type high energy amputation, then clearly the early priority is just the preservation of life. And so that's all the stuff that you guys know as well as I do with, tourniquets, binders, early use of blood, controlling the systemic inflammatory response. And if you're interested in the kind of specifics of the wound management, then I recommend this paper, which is the military team from Birmingham. Dimitri Evribriades was the lead plastic surgeon on this paper. And they really talk about how you manage the progression of a wound, the tissue dieback that you get from a blast injury, some kind of lesser known, lesser appreciated problems like invasive fungal infections. And really, with the wound that you can see here, the priority is saving life and getting them past this point, which will probably involve, skin grafting large areas of this wound, which isn't great for your functional reconstruction, but it's just about getting control of the wound, getting the patient to a point where you can then think about the more complex surgeries once that patient and the wound is stabilized. Now, I love microsurgery. I love limb salvage. It's what I'm kind of going to base my career in. But the decision to amputate versus salvage a limb is very difficult. And there are a number of scoring systems out there, none of which are very well validated and none of which are really very well used. There are some UK guidelines for amputee care as part of the kind of limb salvage care called the BOAST-4 guidelines. And they're a joint British Orthopaedic and British Plastic Surgery Society guideline, which are worth reading. And they state that amputation, the decision to amputate should be a 2-consultant decision, ideally one from plastics, one from orthopedics. The conceptual difficulty that we're almost getting to the point of reaching is that the early kind of 2000s, there was a big study in the US called the LEAP study, the Lower Extremity Assessment Project. And they looked at limb salvage versus amputation and found that limb salvage is probably preferable over the long term. But amputees can often get up and walking faster because they don't have to deal with, the bone healing issues. In a military population, so the US, it was the metal study, and then there's a UK study from Headley Court, as it was then. They've actually found that amputees in a military population do better than limb salvage in many cohorts, and that's because you can be up and about in a prosthesis from 6 weeks, and you can get up and running faster than if you have a long, prolonged limb salvage. And that's true for people who have an acute amputation or even a delayed amputation. Limb salvage is a very problematic problem. It's tricky to get the bones to heal well, to resurface the soft tissues. And amputation, you can control the wound somewhat better. And so with the advances in prosthetics, we will be getting to a point where you may have better early outcomes from amputation than limb salvage. But it's a nuanced discussion, because do you want to be 70 dealing with a prosthetic, dealing with the kind of complexities of being an amputee versus, just getting about well, walking on your salvaged limb, compared to being someone who wants to be really high activity in your 30s and 40s and running and skiing and whatever else, in which case you might be better off with an amputation in that time frame. So the studies are ongoing, and it'll be interesting to see how the pendulum shifts. But it's a big decision to remove a limb, and so even if amputees have better outcomes in the early and medium term, I think people are still going to be very keen on salvaging limbs wherever possible. And so in our military population, they've really shown us how they can push the limits of what's possible as an amputee. They're very well represented now in the Paralympics, and these are some of the guys from the last Olympics. But the amputee who I've been most interested in following this year is Harry Buddha-Magar, who is a Gurkha soldier, bilateral transfemoral amputee from Afghanistan, and he summited Everest this year as a bilateral above knee amputee, and even walking as a bilateral above knee is quite an achievement. And so it is staggering that he was able to climb Everest as he did. And so we need to have some surgical humility and understand that the foot is an incredibly complex thing. It's a marvel of engineering. It's got the thickest dermis in the body. It's got the most dense fibrofatty tissue. It's got 4 layers of muscle. It's got the calcaneal bone, which is the hardest bone in the body. There's 2 separate osteoligamentous arches that can absorb the forces of gait. And you can't think that you can replicate the complexity and the function of the sole of the foot just by flapping over some skin and fat over the bone end and thinking that that's going to do your job. And so surgically, you are going to provide the patient with an inferior walking surface than they currently have or they had prior to the trauma. And surgery is only a small part of that. The prosthetics is a huge part. The rehabilitation is a huge part. Pain management is a huge part. The social work and the kind of the psychological and the psychosocial aspects of being an amputee, and also the cost, like who's going to pay for the prosthetics that they may need, some of the customs that they might need if they're going to be an athlete, and the ongoing increased cost that being an amputee entails. And so when we think about amputee care, there's a kind of a mental construct of Maslow's hierarchy of needs. So in the 1950s, Maslow had this pyramid. Well, he had the concept of a hierarchy of needs, and you have to fulfill basic needs before you can fulfill higher needs. So you don't worry about self-actualization or esteem needs until your safety needs and your physiological needs are met. The modern update is Wi-Fi and battery as the base needs, and I can feel that sometimes. And so my mentor and the guy I spent most time with during fellowship was Jason Souza, who was the head of reconstructive surgery at Walter Reed and is now at Ohio State. But he came up with this concept of an amputation hierarchy of needs. So the basic needs of an amputation are to ablate the limb, remove the diseased or traumatized segment. And then the next basic need is control the pain. So minimize their post-amputation pain, minimize their residual limb pain. Once you've dealt with pain and removing what needs to be removed, then you can think about functional restoration, prosthetic control, and sensory feedback and physiologic feedback. And then once you've established that, you can think about the aesthetic needs of the residual limb and the shape and the contour of the limb. And so when we consider what makes a good amputation, we want to think about, we want to think about the various surgical components of that. And so first up, we're going to think about length. And these concepts are not mutually exclusive. So length and padding can overlap, pain and sensation overlap, control and proprioception overlap. But there's kind of separate concepts with each, which can be helpful to deal with. So length is a really key consideration to amputation long-term outcome. You will do far better as a below knee amputation than an above knee amputation than a high above knee versus a hip disarticulation or a hemipelvectomy. The foot and ankle amputations are really more for lower demand patients and diabetic vascular patients. They're quite good for transferring and for walking, but you're never going to run on a Symes or an ankle disarticulation. You need space for the prosthetic component. So a young patient with a devastating mid and hindfoot injury is going to have a below knee, and that's going to be the most functional amputation for them. Going a level higher is a significant impairment for an amputee. And so don't ever think about revising an amputation higher unless you've talked to a plastic surgeon who might be able to bring in more soft tissue and salvage that lower level. So in this 6-minute walk test table data that you can see, this is US military patients. You can see that without limb loss, a normal patient will walk an average of 760 meters in 6 minutes. A below knee, a TTA, a transtibial amputee will walk 660 meters, so really not that far off. A transfemoral drops by more than 100 meters to 540. And what I found interesting was that a bilateral transtibial, so a bilateral below knee amputee, will walk further than a single unilateral transfemoral amputee. And then when you get to bilateral above or below, or bilateral above, then those distances really start to drop off. And the distance you can walk in that time is only part of the story. The energy it requires to actually walk with an amputation is far higher, and the higher the level gets, the more energy it takes. And so there is a lever arm concept of amputations where you don't want the bone to be too short because you want it to be an effective lever arm, and you want the bone to capture the socket. And so the longer the bones can be, the better, as long as you have enough space underneath for the prosthetic components. So a lot of people talk about 10 or 12 centimeter amputations for a below knee. And that's something I think that's come from the vascular literature because they don't heal very well. But 10 centimeters is too short, and you only get revised higher if you have a problem and you need to nibble away some bone. So my mentor and my story is always think about 15 centimeters from the joint line, even 16 if you're tall. If you put your hand on the knee and cut below it, you've gone too short unless you can really justify why you've done that. And so length is a key consideration, and the bone will dictate the length. The soft tissue shouldn't dictate, because you can always bring in more soft tissue if you've got the right people around you. Padding is the next kind of key consideration. So as we spoke about, that the foot is a very complex structure with fasciocutaneous padding and muscle padding, and is very specialized for that. There are different soft tissue envelopes you can put around an amputation. And the below knee, people talk about posterior flaps. So a big bit of posterior skin, the gastrocnemius muscles, the soleus muscles, and the skin from the back of the leg, and flip that up. You can also do what's called a skew flap. And there's a Cochrane review showing that if you know what you're doing, they're essentially equivalent. But the posterior flap is probably more common. As we said, there may be areas that are skin grafted just to get temporary control, and there might be areas that you want to excise later on and cover with local or free flaps. And you get kind of wearing through of areas that aren't well padded. So that anterior tibial border that you can see on the photo, you can't see my cursor. You can't see my cursor. This anterior tibial border is often a problem, and if you don't get your suture line above it, you can wear through here. And so that's exposed tibia because his posterior flap has slipped back off the bone end, which you can see here. This is verrucous hyperplasia, which you get from being in a socket a long time. It's a viral activation of warts that can just cover the whole stump. And that's because they're in a sweaty, hot environment the whole time. And this is a patient I looked after in Ohio who flew into Ohio because he was told he needed bilateral above knee amputations because he had widespread necrosis of his legs. And actually, with 2 free flaps to cover his knee and reconstruct the extensor recinaculums, we kept him as below knee and bilateral above arm. So he needed five free flaps to keep him below knee and below elbow. And that will be significantly more functional in the long term than if he was bilateral above knee and bilateral above elbow. The soft tissue envelope changes. You don't have to get it perfect first time, but the myodesis, so attaching the muscles to the bone and getting the muscles to the right tension, is best done at the time of first closure. And then some soft tissue nip tucks can be done later on. Pain is a huge part of being an amputee and a huge part of amputation surgery. It's really only in the last 10 years that some of these new concepts have emerged as to how to best manage pain in prosthetic care and in amputees. So, talking about pain with amputees is an hour or two in itself, and so I'm going to have to gloss over some things. But essentially, there are 3 parts of pain when it comes to amputee care: phantom pain, neuroma pain, and residual limb pain. All of them are worse if the acute pain is poorly controlled. So if you are a pre-hospital provider, a paramedic, or an emergency physician, really think about how you can influence their acute pain, because we know that the better the acute pain is controlled, the less severe the chronic pain often is. Phantom pain is part and parcel of being an amputee because it is controlled centrally in the brain. You have had a cortical representation of your arm or your leg from birth. And when you lose your arm or your leg, you don't lose that cortical representation of it. And so you have a brain who's trying to fill in the limb not being there, and you will always have some phantom sensation. Whether you have phantom pain is a different story, and phantom sensation can be managed. Phantom pain is more problematic. Neuroma pain is pain at the end of the nerve because you've cut a pain and now you've cut a nerve, and now you have a live wire. And there's a whole host of strategies as how you control that neuroma pain. And residual limb pain is everything else. You've got pain from bone spurs, from heterotopic ossification, from bursas at the end of the bone, from skin irritation from being in a socket. And that's harder to manage surgically. And so it's not just about the surgical management of pain. There's a whole pharmacological, interventional pain specialist and rehabilitation and holistic strategies. So we spoke a bit about the kind of peripheral and the central components of pain. And if you have peripheral pain for a long period of time, you centralize that pain. And even when you treat the peripheral pain, you will still experience the pain centrally, which seems very unfair. And so there is a time window for treating peripheral pain. We spoke about the importance of the acute management, but even within the chronic management, you want to be treating that pain within the first 6 to 12 months, because by 2 years, pain is centralized. And this is somewhat controversial, but I think I've seen it, and I think I believe what I'm saying. And so by 2 years, pain is centralized. And even if you treat the peripheral pain at that point, you won't get as good a result because of the centralization of that pain. So what to do with nerves is what I'm really interested in. That's my kind of area of kind of fellowship. I think we can go into more depth than we need to, but essentially there's something called targeted muscle reinnervation, TMR, and that's giving the nerve somewhere to go and something to do by putting it back into a muscle target nerve. And it's the best evidence. And these other strategies such as capping, grafting to nowhere, RPNI, which is a regenerative peripheral nerve interface, so putting it in a muscle wrap or just dunking it in muscle, they were all reasonable options, but they are less well evidence-based than TMR. So doing nothing is essentially cutting a nerve, letting it retract back into soft tissue where it's not going to be irritated. And that's totally reasonable and a pretty sensible first line. What you don't want to do is ligate a nerve. You don't want to suture tie a nerve because we know that causes neuroma, and that causes significant neuroma pain. In animal models, if you want to create a neuroma, you tie a nerve. And so where possible, don't tie nerves off. Just cut them short and leave them be. Or if you want to do an intervention, then TMR would be the first line. TMR has got very popular, partly because it's new and everyone's enthusiastic about adopting it. It's also very well reimbursed in America. So everyone in America wants to do TMR as part of their surgery because they get paid well for doing it. And the basic science is actually starting to lag behind the commentaries and case reports and technical reviews and reviews of what to do. And so there's far more literature about TMR from a kind of commentary point of view than there is from an outcomes and basic science point of view, which is a shame. So there are a number of randomized controlled trials that are recruiting. But the problem is that if you do TMR badly, it's probably worse than just cutting the nerve and leaving it short. And so improper surgical practice may pollute the data in terms of what kind of outcomes you can expect. So the question is should all amputees get TMR at the time of surgery, what we will call prophylactic TMR? Now, actually, just fundamentally, that's impossible. There are far more amputations going on in the NHS every day than there are, plastic surgeons or orthopedic surgeons with peripheral nerve experience that would be interested in doing TMR. And so not everyone's going to get them. So it's more about identifying who should have them. We know from this kind of meta-analysis and others similar that the pooled prevalence, so the kind of the likelihood of getting phantom limb pain or significant neuroma pain is probably less than 50%. So if you treat everyone with TMR prophylactically, you're over treating more than 50% of people, because more than 50% of people wouldn't have experienced that pain that you're trying to treat. If you want to read a kind of how-to or a consensus on TMR, then this Carl Eberlin paper is the one to recommend. These are all the big names in the US of TMR, and that's kind of really trying to standardize the terminology and the concepts around it. RPNI is a reasonable option, as I said, and there are some nerves where you don't have good targets for TMR, and so RPNI is a good second best. There are people who are promoting it as an equivalent to TMR. I think my feeling is that if TMR works, then RPNI may also work, but it can't work as well conceptually. The number of targets, the number of places for the nerve to go are never going to be as much in a small piece of muscle graft wrapped around a nerve as it is on a proper nerve coaptation for TMR. The other problem with the data is that the control that they used for their main randomized control trial was suture ligation, which we know is the worst thing you can do to a nerve. So their phantom limb pain prevalence was up in the kind of 90%. And we know from the meta-analyses that that's higher than it should have been. It should have been in the 50%. And so their phantom limb pain from the prophylactic RPNI was around 50%, which is what we think the pool prevalence is. So this paper wasn't particularly convincing for me, even though it's kind of the most popular piece of evidence for RPNI. So my pain top tips for kind of surgery and for multimodal pain is just do something thoughtful with the nerve. If you see a nerve, do something thoughtful with it. Get it out of the way. Don't catch it in a suture. Don't have it right on the end of the bone. Get it proximally away from the weight-bearing areas. Pregabalin is a great pain drug that every amputee should have early on, and if they can wean off it at 6 months, great. But certainly for that acute phase when the nerve is unhappy because it's been cut, everyone should be on a gabapentinoid, so either pregabalin or gabapentin. And that's something that in our practice in Ohio, we were starting very early, and we would encourage people to start earlier, I think. The main side effect is drowsiness, which in the acute setting is no bad thing. Ketamine is another drug that I'm a huge fan of in a chronic pain setting, but also in an acute pain setting. And it has a central effect that we're only really starting to understand. And so using ketamine for the acute pain and an amputation will have a benefit for 3 months. And whenever you do revision surgery and you mess with nerves again, you probably want to be using ketamine again intraoperatively. And sometimes people are using postoperatively as well, because of that central effect that it has. You don't want the nerve to know that it's been messed with. So nerve blocks at the time of surgery, either local injecting the nerve just before you cut it, or a nerve block by the anaesthetist is always going to be helpful. Other things such as duloxetine can be helpful. Topical therapies such as lidocaine or capsaicin. And then people have reported benefit from CBD oil, acupuncture, hot cold, anything that works is great. And mirror therapy is a well-known kind of trick that you can use in the therapy setting for amputees. And there's a whole kind of host of therapy options that are also really important for pain and need kind of early liaison with the therapist to avoid that centralization of pain and try and get the brain to understand the new layout of the nerves and the missing limb, and to avoid kind of maladaptive strategies with coping with that pain. And so the next consideration with amputee care and a good amputation is how do you control that amputation? So myodesis is the concept of putting muscle on bone to stabilize the bone. Thigh-plasty is about the kind of soft tissue envelope, particularly in the above knee. And then change in weight is where you need to do revision surgery because everything gets a bit wobbly. And osseointegration is a new concept. But all of these things really are surgical options when surgery is probably only 10% of prosthetic control. And everything else is about having a good prosthetist. You can get a really good capture of your residual limb so that you get the best possible control of your prosthesis. Thigh-plasty is just about removing the spoon and jelly concept. So your bone is the spoon and jelly is your soft tissue. You're trying to capture the movement of the spoon for the movement of the prosthetic. And the jelly is a poor interface for that. So the tighter you can make the soft tissue envelope, the better your prosthetic control. And a thigh-plasty is a kind of, cosmetic type surgery that really nearly every above knee amputee would benefit from, to minimize the amount of soft tissue around the muscle and the bone envelope. So in this patient here, you can see the markings and the amount that you can pinch to remove, and you can see the size of the muscle, and this is the bone end with the hole in because they're having OI. But this is bone, this is muscle, this is all you really need. Everything else is fairly superfluous in terms of prosthetic control. And so the less fat and skin there is around that, the better in terms of prosthetic control. And there's good papers that the tighter that envelope is, the better the walking speed and the prosthetic control patients get. Osseointegration is a relatively new concept in amputee care. It's been around in Europe for probably 20 years now, and in the US probably for about 10 years. In the UK, there's a growing experience. It's done privately in London, and it's been done in Birmingham in military and veteran populations. But the NHS is looking at how they fund this for other amputees going forward. Essentially, there are a few different devices on the market. There's the OPRA system, which is the screw fit, so it screws into the bone, and you have to do that as a 2-stage, and then you can really thin the skin over the bone, almost like a skin graft. And then there's the press fit, where you just kind of core the bone out, press it in. It's an interference fit until it osseointegrates. And then you have a thicker soft tissue envelope around what we call the abutment, the bit of metal coming through the skin. It's a trade-off. It's not a solution. It's not perfect. There are issues with it, and there's a real nuance around patient selection. But I think for an above knee amputee who's struggling to get a prosthesis to fit, it can be a game changer. And for a transhumeral amputee, there's pretty much no reason not to have it in terms of how well you can suspend a socket and how many hours a day you can wear that prosthesis. There are a range of motions and prosthetic control that you just can't get with a socket-based amputee. You can't flex your knee in an above knee amputee to this degree on the rower, as this guy is demonstrating. And so he's an above knee on one side and a below knee on the other side. And you can't have the external rotation and the shoulder control that this transhumeral amputee is demonstrating, or really the non-observed control of your limb that he's showing here with the balance of his above knee amputee. There's a concept of osseoperception. So when you're walking on the ground, you can feel in your bone if you're on an uneven surface. And with osseointegration, because the prosthesis is clicked directly into the metal that is interfaced into the bone, you can also get a feeling of where your leg is in space and where it is on the ground, which means you don't have to look down as much. And so for uneven walking on uneven ground, osseointegration can also be a real game changer. So patients like it. They report improvement in all domains. They report fewer problems than wearing a prosthesis. In the upper limb, they report higher DASH scores, which is this upper limb scoring system, and much higher prosthetic use. And the main problem is infection. But actually deep bone infection is really only seen in about 5% in this paper, which was the US military experience. And so it's an exciting thing for the right patient, but it's not something that you would see used in the acute setting. I think people need to fail at using conventional prostheses, and then OI needs to be a slow time discussion in clinic about these are the risks, these are the potential benefits, is it something you want to try? And so even newer than osseointegration is something called an AMI amputation, an agonist-antagonist myoneural interface. It's also called a Ewing amputation because that was the first patient. It came out of Matt Carty, who was a limb and breast surgeon in Brigham and Women's Hospital in the Harvard system, and Hugh Herr, who was a PhD scientist who's also an amputee, and so was very interested in amputee and prosthetic engineering. And so the concept is whenever you bend and straighten your arm or your leg, there is a pull and a push on the muscle. And so as one muscle shortens, the antagonistic muscle lengthens, and your brain is aware of that through proprioception. And that's why you know where your hand is in space based on the relative tension between muscles. You lose that relationship between agonist and antagonist muscles when you have an amputation. And so you lose proprioception. It becomes an open feedback loop. And it's thought to be a reasonable component of phantom sensation and phantom pain. And so if you can reestablish the relationship between agonist and antagonist in the amputation, then you close that proprioceptive feedback loop, and you can pull and push your missing hand or missing foot by re-establishing the connection of those muscles. So in the Bologna amputation, essentially the main one is tib post and tib ant and gastroc. So your gastroc brings your foot down, tib ant brings your foot up. If you reconnect them through a little tendon tunnel and suture that tunnel to the bone and tension the muscles appropriately, then the patients can, in their own mind, kind of flex and extend their phantom foot. And so the muscles move, the tendons move, but the foot's not there. So obviously the foot doesn't move, but in their head, the foot does move. And so if they have an itchy foot, they can wiggle it and it seems to relieve the phantom sensations that they have in their foot. And the data was relatively early. It's only a few years old, but it does seem to show benefit both in pain scores and in the sense of embodiment that you get with your prosthesis. So how you feel that the prosthesis belongs to you and that this is now the normal kind of setup for your body. You can use bits of the tarsal tunnel, which is kind of around the back of the ankle, or you can use the extensor retinaculum from the front, or I've also used periosteal flaps to create these tunnels as a gliding surface for the tendons to move in. And this is the kind of Bologna setup. There are above knee constructs and kind of transradial and transhumeral concepts, but they get a bit more complex. And you can RPN either nerves or you can TMR the nerves, as long as you don't take down the muscle groups that you're preserving for the AMI amputation. So proprioception is a kind of interesting area of change in practice in the surgical care of amputees. It's only been done in a handful of centres, and so it's something that I will hopefully bring to the UK because I've been doing it with Jason Sousa in Ohio, and I'll be interested to see if the long-term data supports it. But it's really low risk. It's using parts that you'd otherwise be throwing away, and there's a bit more kind of grafted tissue, so there's an infection risk in theory. You'd have to choose the right patient for it. But in a clean kind of semi-elective amputation where all the disease is distal, I think it can be quite a good option. It just prolongs the amputation by an hour or so. Sensation is the thing that we haven't really sorted out. There are no sensate prostheses. People have spoken about targeted sensory reinnervation. They've spoken about putting implantable devices directly on the nerve in a variety of strategies. But unfortunately, whenever you put something straight on a nerve, it ends up scarring in and can be quite unreliable. And so a sensate prosthesis is a great idea, but it's really only in the research realm at the moment and is not something that we've been able to bring into routine clinical practice. So what makes a good amputation? We spoke about length, we spoke about padding, we spoke about pain, we spoke about prosthetic control, proprioception, sensation, and we spoke about the amputation hierarchy of needs. So addressing the basic needs, and in the historical segments we start with, that's all they could do: keep the patient alive and ablate the diseased or the traumatized distal limb. And now we're above that. We could think about minimizing pain through the strategies we discussed. We can talk about maximizing function through the strategies we discussed. And then there's an aesthetic component as well. And so that's kind of my thinking of amputation care from a surgical perspective. But clearly, as I said before, surgery is really only a small part of amputee care. And so you need that liaison with the therapist, with pain therapy, with the funders, the prosthetic funders, and so that your patients, if you have to amputate a limb, you know that your patients are going to see the right people and that they'll have the best onward care. And there are some problems that are easy prosthetic fixes, and the prosthesis will just deal with that and you never have to get troubled with it. But there are some things that are hard to fix prosthetically and are easy to fix with a small surgery, just a little nip tuck to tighten up the soft tissue envelope, for example. And so it's important to have that two-way dialogue with the prosthetist to ensure that you are following these patients up and addressing problems as they arise in the ongoing care of an amputee. Essentially, an amputee is a patient for life. They will always have problems with a socket, and you need to be available as a surgeon to manage those things if appropriate. So that's kind of my overview of amputee care with a kind of military flavor. And thank you for dialing in on a wet evening. But if you have any questions now, I will go into the chat and the Q&A if I can answer any questions. Okay. So we have, osseointegration infection. It's the big concern, and it's the biggest problem. And there are nuances between the different devices. So there's the compress system, which is a Zimmer Biomet. It's currently undergoing an FDA trial in America at the moment. The push fit, OTN, OPL, and then you have the screw fit, which is the OPRA system. If they get infected, essentially, if the bone gets infected, they need to be removed, and then you need a period of time to recover from that infection. And everyone I've met who's had one removed is desperate for it to go back in. There's been no kind of life-threatening infections from these things, but a bone infection is no joke, and it is at least a 6-week, 3-month course of intravenous antibiotics and whatever else. But I think, as our understanding of the soft tissue management and the bony management, the infection rate is going to drop, and 5% at the moment is not unreasonable. The next question is on so in infections, if it's a soft tissue infection, you just treat the soft tissue. If it's a bone infection, you need to remove it, essentially. And if you remove it, there are ways of getting it out. You don't have to remove the bone entirely. There are people that worry about going an amputation level higher because you've osseointegrated the bone. Most of the time, you can just get it out, and then you have to let the bone heal, resample, and then you can put it back in maybe 6 months later. And in that intervening time, they should be able to go back to a conventional prosthesis. They shouldn't be wheelchair bound. But for some patients, it can be catastrophic, because if they've been used to living as a osseointegrated amputee and they're able to walk without, undue consideration, they're not in an adapted house, they don't have a wheelchair anymore. If they then suddenly go back to being a wheelchair user, that can be really devastating for them. So best timing for prosthetic use. So if you do a kind of a semi-elective amputee, so if you've got like a non-salvageable foot or a chronic osteomyelitis that is going to convert to an amputation, you want them to be seeing the prosthetist at 6 weeks. That's probably ambitious, but actually there are some young patients that will be in a prosthetic at 6 weeks. They're going to need refitting because the volume of the prosthesis the volume of the residual limb will change as the fluid comes out of it within the first 3 months. But the earlier they're up and about, the better it is for them psychologically, and the better it is for controlling the edema in the residual limb, because the compression of the prosthesis is the best thing for controlling that edema. I think we're going to see more and more patients that benefit from osseointegration. I think primary osseointegration is a difficult concept, because in trauma, you never know if the bone has got an infection that you didn't know about. I think my experience with osseointegration is when it works, it's great. When it doesn't work, it's problematic. And if a patient hasn't experienced being an amputee, the only thing they have to compare it to is life before the accident when they were walking normally. And now they have life after the accident, where they have an osseointegrated implant, which is just causing problems. And if they haven't experienced the problems that OI is solving, they don't appreciate the full benefit of OI, if that makes sense. So I think it may be that OI comes in earlier and earlier for the right people. And certainly for an above elbow, it's really hard to hang a complex myoelectric prosthesis off your arm. It's uncomfortable. You're limited to a few hours. And there may be a role for direct OI for an above elbow, and the blood supply is better in the upper limb as well. Infection's less of a problem. In the lower limb, I think you want people to see what they can do as a as a kind of regular amputee, and then think about OI. The other problem with OI is there's an interface between the bone and the metal, and they have different stress strain capabilities. And so if you overuse an OI, there is a risk of getting bone fractures or even metal fractures. And so you don't want to be an OI user who is jumping out of airplanes, skiing aggressively, or running. You want to do that stuff as a conventional amputee and just deal with the socket problems. And then if you just want a limb that you can clip on and walk and not have to think about, then you want to go to OI. So if you want to be a kind of a sprinter, you don't see Paralympic athletes with OI, because you can't overstress the OI to that degree, is our understanding at the moment. If you had to do an amputation on the field, so if you had to amputate a limb to remove someone from a trapped environment, or because you couldn't, for whatever reason, if you had to amputate on the, if you had to do a kind of pre-hospital or emergency department amputation for hemorrhage control or whatever else, do everything as distal as possible, and don't worry about exposed bone distally. Make everything as distal as possible, like evacuate or get to a specialist center, and you can just managing everything else with dressings is fine. There were patients who came back from Afghanistan with a limb that looked a bit like a turkey leg. It was kind of, an exposed distal femur with proximal muscle that was alive, and the specialist can work out, how to salvage and maintain length. If you're a non-specialist dealing with an amputee, keep it as distal as possible. That'd be my answer to that question. TMR. I don't think TMR is futile if you do it late. I think it's a reasonable option. You just need to discuss with the patient that the outcome might be less reliable. I think TMR is getting increasingly well understood by surgeons in training as they come through, and so I think we'll see more of it. It's just still in the early days in the NHS. Centralization is definitely a problem, and the other problem with TMR in a delayed setting is you do stir it up. You are re-injuring the nerves, and so phantom pain can get worse within the first few months of TMR before the nerve has regrown into the muscle and you've given it something to do. So you can make things worse for a few months with TMR before you make it better, and so the patients have to understand that. Okay, CMTs and pre-hospital clinicians in the role one assist surgeons in receiving patients to get a favorable outcome. That's a good question. So pre-hospitally, I would say you preserve traumatized tissue by properly resuscitating a patient, and you minimize chronic pain by treating acute pain. So in a pre-hospital or a paramedic type environment, focus on not traumatizing what tissue is left, resuscitating the patient appropriately, and managing their pain as best possible. And if you're appropriately trained, then pre-hospital blocks are great. Pre-hospital ketamine is great. All those things are things that you can think about in a kind of pre-hospital presentation. Yeah, so David Hart's asked about balancing initial treatment and do you stay and play, or do you kind of so I'm a plastic surgeon. My pre-hospital experience is a few years back now, and I'm probably not the right person to answer that question, but there is always a balance between on-scene initial treatment to optimize resuscitation versus getting them to a major trauma center. I don't think being an amputee changes that dynamic. If a patient is unstable, then it's a judgment call about how much you do on scene versus how quickly you get them to a trauma center. An amputee, I don't think, is a specific patient scenario. It's just a trauma patient who may have lost a lot of blood. Thanks everyone for the nice comments. Yeah, happy to chat offline. My email is there, so just shoot me an email. But yeah, we'd love to chat to anyone. Yeah, so TMR for people who have nerve damage post-surgery. Yeah, so the great thing about TMR in an amputee is you are reinnervating into muscles that don't have a function anymore because the foot or the hand or the knee that they used to work on, they're gone. TMR in muscles which still have a function is more nuanced, and you have to be aware of how many motor targets go into that muscle and how much of that you can take away in the treatment of pain before you start affecting function. But TMR is definitely an option in nerve damage for pain. It's a great treatment for pain, and if the nerve is I'll try and give you an example to explain. So you might have an ankle surgery, invert your ankle, really damage the superficial peroneal nerve, which supplies sensation to the dorsum of your foot, the top of your foot. You can have chronic intractable pain from damage to that nerve, and it's often quite a bad actor. It reacts badly to being injured. And so if you have pain to the SPN, the superficial peroneal nerve, if you TMR that SPN, then you have made the dorsum of the foot chronically numb. And that in itself isn't too much of a problem. And most people would rather a numb foot than a chronically painful foot. The question is, what do you do with it? And you can put it on a minor foot everter, so like peroneus brevis. You don't need that muscle for normal gait. And so you could do a SPN to peroneus brevis TMR as a totally reasonable strategy for pain. That's kind of off topic, but that was the question. Cool. I think that is it for questions. If there's a question that I haven't answered, please just ping it in now and I can get back to it. Cool. Thanks, everyone.
I just need to.
All right. Yeah, we'll leave it there. Anything?
It's really nice to see all of the thumbs up, and glad you got some really interesting questions. I probably understood about 5 words of the entire thing. As someone who's not got a medical background. So something completely different for the next webinar is evolving expectations in pre-hospital risk management. A paradox? Yes, that's my answer to that one. And that's going to be presented by Christian Cooper, and that's on November the 29th. And if you're not a member, you can purchase your CPD certificate either by scanning the QR code, or if you can't scan it, if you email us at admin@traumacare.org.uk, we'll send you the link to fill in the feedback and purchase your certificate. And none of these webinars would be possible without our sponsors, and QualSafe is one of those. If you want to check out what they do, please go on their website, or you can chat to them at our next conference in March, because they'll be there. And another one of ours is Galen. Again, if you'd like to check out their products, please go to their website, or you can chat to them at our next conference. And Icarus, I believe they do more simulations. They don't tend to come to our conferences, so please check out their website if you are interested in what they do. And we're growing our academic partnership to get more students and non-health registered folk partnered with us. And these are the current institutions. If you've got any recommendations for any schools you think might be interested, please drop us a message at admin, and we'll see what we can do to either get your institution signed up or any other institution in the UK. And that's it from me. Thank you so much, Matt. It's been a really interesting webinar. And I hope everybody has a really safe night, because it's windy and it's rainy and disasters happen. So have a good night, everyone.